Please help me welcome one of our own and a regular speaker at ACC, Julie Dombrowski. Julie is Associate Professor of Medicine here at the University and Deputy Director for Clinical Services at the Seattle King County STD Control Program and Co-Director of the UW Public Health Capacity Building Center. She's also one of the founding directors of the MAX, or Maximum Assistance Clinic, for those toughest to engage HIV positive. Her research focuses on the care and delivery of HIV and STD services. And after the last time that she spoke at AIDS Clinical Conference, she was one of 4 speakers at that conference, including me. Several people came up and said, what a fantastic speaker. I don't know what that means for the rest of us co-lecturers. I like to think that we were all great. It's just that Julie was so fantastic. Yeah. So her talk this morning is STIs, New Realities, and Clinical Controversies. Please welcome.
Thank you very much, Bob, and good morning, everybody. And thank you to the ACC team very much for giving me the opportunity to speak today. Not advancing. There we go. Okay, so I'm going to start today with an update in epidemiology at both the national and local levels. Focus on 5 things that all HIV clinicians should be doing with regard to STD care. Then I want to touch on a couple areas where our local standards of practice differ from published guidelines and review some clinical controversies in the field. At the end, I will briefly review some upcoming studies and additional resources. Bacterial STI rates in the US are undoubtedly rising. When CDC released the most recent surveillance report for 2016, they emphasized the fact that for the 3rd year in a row, rates of syphilis, chlamydia, and gonorrhea were increasing. For chlamydia, the most common bacterial STD, as you can see on the bottom, this was a 5% increase from 2015 to 2016, which generally reflected the long-standing trend in increases in chlamydia. However, for gonorrhea, this was a 19% increase from 2015 to 2016, and this trend in increasing gonorrhea has been coming up from a historic low in 2009. And syphilis is really where we see the most remarkable increases. You can see that steep curve with an 18% increase from 2015 to 2016. Men who have sex with men are the most affected by this increase in STIs, and heterosexuals to a lesser extent, though STI rates are increasing there as well. At the national level, CDC isn't able to report on infections in men who have sex with men because the gender of sex partners is not routinely tracked in all areas. But you can see this reflected in the changes in male to female ratios of syphilis, shown here with men, the blue line, and gonorrhea, where you can also see the steepest increase in men. Here locally, we do track gender of sex partners and are able to describe numbers and rates in men who have sex with men. And you can see our really impressive syphilis increases over time in this slide from 1994 to 2016. Men who have sex with men are reflected in the red bars. We had 617 cases last year, which was a record. But as you'll notice, we had a record the year before that, and the year before that, and the year before that. The yellow bars, men who have sex with women only, and women are shown in the bottom. And although they are much, much smaller than the numbers of cases in men who have sex with men, we have seen an increase there as well. Importantly, this has been in a highly marginalized population. Most of the heterosexuals who have had syphilis, and the group in which we've seen the increase, are predominantly homeless, and many of them abusing methamphetamine. Of course, men who have sex with men and men who have sex with women only, and women, men who have sex with men and heterosexuals are not entirely distinct sexual networks. And we do see increases of syphilis among MSM reflected in the rates among women and very unfortunately in congenital syphilis cases. You can see the low there in 2012, and CDC has and continues to have a goal of eliminating congenital syphilis. But unfortunately, there too, we have seen an increase with 28% in the latest year of reporting. Now let's look at this in the context of HIV and the local context here in King County. What you see on this slide are trends in the rates of STDs among men who have sex with men. Early syphilis, shown in blue, that steep increase you've just seen. Urethral gonorrhea and urethral chlamydia, those are two predominantly symptomatic infections and things we wouldn't expect to change with increased screening. So that is a sign for us that surely bacterial STI rates are going up. But really importantly and really crucially, HIV has decreased over the same period, 37% over the decade shown here. So why is that happening, and in what context is it happening? Certainly one of the first things people think about and talk about is PrEP. It is important to note, I should go back and say, you'll note that this inflection starts sort of somewhere around 2010 or 2011 is really where the inflection and big increase starts. PrEP came after that, but has increased, and we have very high levels of PrEP uptake here in King County. We have a couple ways of measuring that, and what's shown here is our annual PRIDE survey among men who have sex with men, who live in Washington State, who are attending the PRIDE survey every summer. And we ask them about awareness of PrEP, that's shown in the top two lines, distinguishing high-risk men who have sex with men in the dotted line from lower-risk men who have sex with men in the solid line. And you can see that awareness of PrEP has increased and is nearly complete, especially among high-risk men who have sex with men. And uptake of PrEP, the proportion who report ever taking PrEP, has really increased as well, although that increase really occurred in 2015 and forward. We do monitor PrEP uptake in the population, not just from the PRIDE survey, which is definitely a distinct population, not necessarily reflective of the general population of men who have sex with men. But we do have 6 different ways to monitor PrEP uptake in the population. And with those combined, our 2016 estimates for, sorry, that actually should be 2017, pardon me, released in 2017, are that 36% of high-risk MSM in King County have taken PrEP. That's actually a very high number. And our goal is to get to at least 50% in that group. As we had some discussion with Jared Baton's ACC on PrEP in the last month, once we get to that goal of 50, we will increase the goal. 17% of all MSM in King County, we estimate, have taken PrEP. So PrEP and PrEP uptake really did occur after the start of STI increases in STI rates. But another very important trend is recognition of the impact of viral suppression on preventing transmission of HIV, and what's now known as U equals U, or undetectable equals untransmissible. But of course, we had a good sense of this, and we were learning about the impact of viral suppression on reducing transmission several years ago, and the community has had awareness of this as well. So this is reflected in the PRIDE survey, the same one I just told you about, where we've asked people, do you think that HIV-positive people who take medicines to treat HIV are less likely to give HIV to their sex partners? And you can see that that has increased among both HIV-positive and HIV-negative men over time. So essentially, what we are seeing is that these massive increases in STI rates here in King County and in many other parts of the country are occurring. It's a public health problem, but it's occurring very importantly in the context of a massive public health success. We have effective biomedical prevention with viral suppression or treatment as prevention, and with PrEP. And in that context, sexual behavior of men who have sex with men is changing, and STI rates are increasing. So we now have, this is what I think is the most fundamental new reality for us to recognize, we have a decoupling of STD prevention and HIV prevention. For most of the history of HIV in the US, those two were essentially the same, preventing STD and HIV, and they no longer are. We need new approaches to STI prevention and control. So we see this change in sexual behavior reflected in the demographics and the risk factors of people who are getting syphilis here in King County. So what I'm going to show you now on this slide looks at 3 key risk factors for syphilis, at least historically: HIV positivity, prior syphilis, and methamphetamine use. And you see the change in the proportion of cases that occurred among HIV positive and classically high risk for syphilis folks, shown with this yellow line, 43% in 2010 down to 26% in 2016. The green line are the HIV positive and lower risk. The orange line bouncing around a bit, the negative and high risk, and really a profound change among the proportion of cases occurring among HIV negative and classically low risk populations. And what this tells us, this change in risk profile really suggests diffusion of syphilis from a core high-risk sexual network out into the broader population that's occurring with these increases. Along with a lot of syphilis, as many of you know, any of you who do clinical work, neurosyphilis is also increasing tremendously. In 2017, we had 27 confirmed cases of neurosyphilis among people with early or late stage syphilis. And of course, there were many more cases which we treated empirically or didn't have confirmed or needed to evaluate among people with syphilis and neurosyphilis symptoms. On the bottom, I'm showing you the proportion of early syphilis cases in one of our analyses of King County data from 2012 to 2013. And at that time, with 573 cases over that period, we found that about 8% of people reported having new vision or hearing symptoms, things that are concerning for complicated syphilis. And about half of those, 3.5% had confirmed neurosyphilis with abnormal CSF or an ocular exam confirming ocular syphilis. And in 2017, we had 670 cases with approximately that same proportion, 3%, having confirmed neurosyphilis. So as neurosyphilis continues to grow, syphilis rates, neurosyphilis is also increasing. And this has placed a profound demand on our infectious disease clinic, on our health system in general, in part because it's occurring in the context of no more procaine penicillin. So for any of you who don't know, prior to a couple years ago, I'm not sure exactly when it ran out, we mostly treated neurosyphilis cases in the STD clinic that we diagnosed with 10 days of IM procaine penicillin. Now, without that option, all patients who need to be treated for neurosyphilis need to receive IV penicillin, something that's really challenging to do. Yes. Yes.
So those are symptomatic neurosyphilis cases, not asymptomatic.
Thank you very much. Christina Mara is making the point for those on the webcast about how this is confirmed symptomatic neurosyphilis. Thank you very much. And we will go talking about neurosyphilis a bit more in the talk. So thank you for that point. Doesn't include asymptomatic neurosyphilis. Okay, another trend finishing up the epidemiology section is antimicrobial resistance among gonorrhea, our need to monitor for that. This slide shows gonorrhea cases and incidence by sex in King County from 1997 to 2016. And what you see is an increase predominantly among men, but also an increase occurring among women. We monitor antimicrobial susceptibility through a project called SURRG, or Strengthening the U.S. Response to Resistant Gonorrhea, something that many people in the room lead and participate in. And I've shown just a snapshot here from our quarterly STD report, something that is available to anyone who's interested online. And what you can see on the left is the total number of isolates in 2017 that had an alert value to azithromycin, meaning they passed a pre-specified threshold of minimum inhibitory concentration that led to concern about decreased susceptibility, or indicates decreased susceptibility. We had 27 cases with azithromycin alert values, most of which were among MSM, and thankfully 0 cases that had alert values to cephalosporin. On the right, you can see that the majority of those occurred in the first part of 2017. Lindley Barbie published a paper recently pointing out the increases in azithromycin resistance among gonococcal isolates in MSM in King County. And what you can see here, highlighted with the red bar, is that in 2012 and 2013, no isolates had alert values to azithromycin. But in 2014, 15, and 16, 4 to 5% of isolates had an alert value. The World Health Organization recommends that we essentially rethink any treatment that is less than 95% effective, or translates to less than 95% susceptibility in isolates. So this really suggests we have a perhaps growing problem with azithromycin resistance, and that we need to rethink the role of azithromycin in gonorrhea therapy, as well as other roles in STD. Okay, so I'm going to transition now from the epidemiology update to 5 things that all HIV clinicians should be doing. And I will tell you, this is not just me. I did get input from several other colleagues, just so you know, it isn't me. I get nervous about using the word should, but do want to say these are things where there really isn't controversy. Guidelines are clear, and my having consulted several colleagues, I think there's widespread agreement that these are 5 things we all need to be doing, all of us who are taking care of patients with HIV. Number 1, extragenital screening, something I know that many of you know well, but when we look at data from HIV clinics, it does continue to be incomplete. All sexually active men who have sex with men and transgender or non-binary persons who have sex with men should be screened for rectal and pharyngeal gonorrhea and chlamydia. They should be screened at any site that has been exposed in the past year, regardless of condom use during that exposure. All men who have sex with men and transgender and non-binary persons who have sex with men should be screened at least annually if they are sexually active. And higher risk MSM, those who meet the criteria outlined here, should be screened quarterly. The high risk criteria are those who've had a bacterial STD in the past year, methamphetamine or popper use, 10 or more sex partners, condomless anal intercourse with a serodiscordant partner, or those taking PrEP. This list can be challenging for people to remember, and if it's hard to remember these criteria, I think it's okay to default to Q3-month screening for your sexually active patients, which I think many people in Madison Clinic appropriately do. Self-testing is an excellent option for those clinicians who do not have time or do not want to, or patients don't want to, the various reasons that we may not complete extragenital screening. Self-testing can really fill a role here. There's been excellent work done by Lindley Barbie, Shirisha Danareddy, Jeannie Marazzo, and others implementing this in the Madison Clinic, and it's made a huge difference, improving screening rates and case finding. These posters shown here are available to anyone who is interested in them, those of you who aren't in Madison or STD Clinic. You can email Amy Radford to obtain the self-testing posters. All right, number 2 thing that all HIV clinicians should be doing is treating trichomoniasis with 7 days of metronidazole, not single-dose metronidazole. There was a randomized treatment trial of this single-dose versus 7-day approach for the treatment of trich in HIV-infected women. And what is shown here is the difference in test of cure failures, so failures at the time of test of cure, which among those who had a 7-day dose was roughly half that of those who'd had a single dose. And at 3 months, that difference remained. So no more single dose metronidazole for trichomoniasis treatment. Number 3. Yes, sir. Yeah, that's a great question. So I actually think it should occur and is preferred with HIV negative women as well. There have been studies on that, one presented last summer. The guidelines still officially recommend either, though I would say that 7 days is almost certainly a superior treatment in HIV negative women as well. Thank you for that. Okay, number 3, treat STD contacts empirically. This means when someone comes into clinic and says that one of their partners had gonorrhea, chlamydia, or syphilis, either because the partner told the patient or the health department called and told the patient, they need to be treated empirically, not just tested. And the rationale for this is, first, we have a high pretest probability of infection, right? Syphilis, gonorrhea in particular are very, very transmissible. Estimated syphilis transmission, 30% per sex act. And very crucially, syphilis screening can be negative very, very early in infection. Keep in mind, people may be coming to you having heard that they're a syphilis contact and be asymptomatic, and that could be before they have even gotten to the primary stage. We don't know exactly when the EIA or IgG and the RPR become positive, but we know that about 85% of people with primary syphilis have a positive RPR. So the corollary of that is that there may be up to 15% of people who don't have a positive serologic result very early in infection. And then certainly we have a public health imperative to prevent ongoing transmission, and that's a key role at the time somebody comes to the clinic to interrupt that transmission and to treat them empirically. Please do not just test them and send them out. Number 4, stage new syphilis diagnoses. So this is something that has come up, I think in general, I acknowledge is very widely done, but from time to time, I know there are cases where somebody screens, has no symptoms whatsoever, has a positive RPR, and for instance, triage will ask for an order for bicillin. But whenever we have a new positive RPR, a new increase in RPR, and a new case of syphilis, we really need to interview and examine the patient for a couple of reasons. The first one I'm going to focus on is the staging, right? We need to determine whether that patient is in primary syphilis with a chancre, secondary syphilis with a systemic infection, early latent, meaning no symptoms but a negative test in the past year, or late latent unknown duration, which is no negative test in the past year. And really importantly, that's crucial not just for determining the treatment of the patient, 1 dose of bicillin for early syphilis versus 3 for late latent unknown duration. It's also important for contact tracing and for partner services. So there are different windows of partner notification for the different stages of syphilis. 4 months and 1 week primary to lesion onset for primary, 8 months for secondary, and 12 months for early latent is what's recommended by the CDC. So it helps us a lot in public health when you can stage and document the stage of syphilis. I was interested, just as an aside here, when I went to look for these treatment windows, I was surprised to see the CDC guide for partner services. And this group of people who really look like nobody would want to talk to these people about their sex life. And what's interesting is under the section on effective case management tips, this is who you see. And it's like, I don't know who chose these images. It was really shocking to me. I hadn't noticed that before. And so for any of you who may not be familiar with disease intervention specialists, the field services staff, those people who are talking to your patients and their partners, I want to show you real DIS. These are our DIS. They are a group of friendly people who are understanding, who are non-judgmental, who do an excellent job of working with patients and their partners to get testing and treatment. And syphilis in particular, I'm highlighting Katie, Rolf, and Alyssa, who are 3 of the key people who will be talking to your patients. And that's who you're helping when you're documenting, staging, treating empirically. Thank you for doing that. For anyone on the webcast who this may not be your field services group, I assure you it's a friendly group where you are too. Okay, number 5, and getting to the last of things clinicians should be doing, is screening for rapidly evaluating and treating complicated syphilis. Here I'm using the term complicated syphilis to encompass neurosyphilis, both asymptomatic and symptomatic, as well as otosyphilis, syphilis in the ear, and ocular syphilis, syphilis in the eye. Key questions, and Christina, I will invite your comment on this as well. I'm going to show your paper on the next slide. Key questions, I think, for any of us to think of when we are screening patients for complicated syphilis is, have you had a change in vision or trouble, photophobia, or flashes? Any kind of change in vision really needs to be evaluated at the time of a new syphilis diagnosis. A change in hearing, new or changed tinnitus, and difficulty walking. We ask a number of symptoms, and some of them, like headache, are very nonspecific, but these are some that really should trigger you to do further evaluation for complicated syphilis. Christina Mara's group recently published, Ariel Davis was the first author, a paper in Clinical Infectious Diseases that looked at the association between mild or greater symptom severity and confirmed neurosyphilis with a positive CSF VDRL among patients who were referred to the UW neurosyphilis study. And the key findings on this table are, first, that the symptoms and their association the symptoms were not substantially different between HIV uninfected and HIV infected patients. The associations I've highlighted here in the red boxes. So these are those that were statistically significantly associated with confirmed neurosyphilis. And those were photophobia, vision loss, gait incoordination, and hearing loss at the moderate or severe level. When you have a patient with syphilis and have screened them for neurosyphilis, there certainly is still a debate about LP. I'm not going to get into that broadly here, though happy to address it and talk in the question and answer session. These are the key steps for evaluation. Lumbar puncture, which you need to keep in mind can be normal. in otosyphilis and ocular syphilis. So lumbar puncture is not ruling out otosyphilis and ocular syphilis. If they have vision symptoms, they need an urgent ophtho-eval with an expert ophthalmologist. I realize not everybody has access to that, but certainly here in Seattle and at Harborview we do. If they have hearing symptoms, they should have an urgent audiologic evaluation and can usually get into both of these on the same or next day often. For treatment, as you're evaluating a patient, please don't delay treatment for the evaluation. So if somebody is going to get an LP and it's later, say the next day, I think that we need to give bicillin while we're awaiting that further workup and can change then to neurosyphilis treatment. But please don't let a patient with syphilis leave without getting some treatment, either their bicillin or start for neurosyphilis treatment. Ocular syphilis can be ruled out with a normal CSF examination and a normal ophthalmologic examination by an expert ophthalmologist. Otosyphilis, we don't have any way to rule that out. That is really a clinical diagnosis. So it's crucial that if you have somebody who has new hearing symptoms, new tinnitus, that of course it takes some time to sort that out in the history. In general, those people should be treated for neurosyphilis empirically because we don't have any way to rule out otosyphilis. Okay, so here's the review of 5 things all HIV clinicians should be doing. Extragenital screening of men who have sex with men and transgender non-binary persons who have sex with men. Treating trichomoniasis for 7 days, treating contacts empirically, staging syphilis, and screening for, rapidly evaluating, and treating complicated syphilis. All right, now I want to highlight 2 areas where our local standards of practice differ from the guidelines and talk about why that is for any of you who are unfamiliar. Okay, first, we do have a recommendation, and our MAs try to support in the Madison Clinic, testing HIV positive MSM for syphilis with every blood draw. And this is based on the basic idea that if we can increase testing in the population, we are going to find more cases than we will with essentially clinician-driven screening. This was studied in Australia, first with a study in 2007 where they started testing, adding syphilis tests to routine HIV monitoring for all MSM, and found that that certainly increased the frequency of testing, not surprisingly. And they also concluded that there was evidence of its effectiveness because in the pre-testing everybody period, 21% rather of cases were asymptomatic, and in the post-implementation period, 85% were asymptomatic. And that led them to conclude that they were picking up on more asymptomatic cases with the broad testing. In Australia, they implemented this as part of the National Gay Men's Syphilis Action Plan in 2009. And you can see, shown in this graph here from 2009, how much that increased the number of tests that were done. It's really hard to know exactly how successful this is. Certainly over the same period in Australia that syphilis tests have gone up, syphilis rates have also gone up. Those look very similar to what I showed you here. And we don't know for sure, but there's some debate about this, but the Australians in particular, I think, still feel that increasing detection of asymptomatic cases and the increasing proportion of cases that are asymptomatic represents a success. This is something that you will notice in the Madison Clinic. MAs often will order syphilis testing or suggest it, and you as a clinician can certainly take it off if you feel a need to do that. But in general, I think we should err towards increasing syphilis testing. Rectal chlamydia treatment. This is an area of controversy, but an area where our local standards of practice, at least in the STD clinic, and I would say should be in Madison Clinic for the most part as well, prefer doxycycline for the treatment of rectal chlamydia. The STD guidelines suggest either 1 dose of azithromycin or 7 days of doxycycline for the treatment of rectal gonorrhea. And that's based primarily on data from urogenital chlamydia infections. Many clinicians, despite that equivalent, many clinicians prefer azithromycin. It's understandable. It's a single dose. It's much easier. Adherence is high. We can do it now instead of giving patients a 7-day course. There are many retrospective studies, including one done in the King County STD Clinic by Christine Kozerpour, that suggest that doxycycline is substantially more effective than azithromycin. And there was a meta-analysis done that showed, really estimated the pooled efficacy estimates were that azithromycin for the treatment of rectal chlamydia is about 83% effective, too low for STD treatment, and doxycycline was near complete, 99.6% effective. However, these are retrospective studies. They are inherently biased. We don't know the effect of clinician choice on those outcomes. And as I mentioned, I think the main reason why clinicians often prefer azithromycin is concern about patient adherence. Importantly, I would point out that those data I just showed you are in the context of real-world adherence to doxycycline, which is almost certainly incomplete. And there are some older data that really suggest you don't need 100% adherence to doxycycline to achieve that effect. There are so I would say, certainly in our STD clinic and in King County, the local standard of care for rectal chlamydia treatment is 7 days of doxycycline. There are 2 randomized controlled trials addressing this question. One in Australia, which is really focused on efficacy with intensive reminders and adherence monitoring, and one that will start here in the US, both in Seattle and Boston, in the next few weeks, which is focused more on real-world azithromycin versus doxycycline treatment. Okay, so now I want to move in to discuss 4 clinical controversies. These are areas in our field where there are really experts on both sides and good arguments and points on both sides. And my goal is just to summarize them for you and hopefully stimulate some discussion at the end of the talk. All right, the first controversy is extragenital screening in women. We've just talked about extragenital screening in men who have sex with men and transgender persons. Should we also screen women for rectal and pharyngeal gonorrhea and chlamydia? Women certainly get extragenital gonorrhea and chlamydia. There's no doubt about this. Although at first there was a lot of discussion about whether the positive gnats represented true infection, I would say without doubt, women can and do get rectal and pharyngeal gonorrhea and chlamydia. Isolated extragenital infections, that is a rectal or pharyngeal infection without concomitant urogenital infection, those are the ones we care about the most because they would not be getting treatment if we didn't detect it. Isolated extragenital infections are less common in women than in men who have sex with men, but frequent enough to raise the question of screening. And what I've shown you here is a summary of 14 studies of women attending sexual health clinics. So these are different demographics and risk factor pools of women, mostly at sexual health clinics. And what that estimated was overall about 6% of women tested positive for rectal chlamydia. Among those who had urogenital CT, 68% tested positive, actually a very high number. Rectal CT positivity, isolated infection, however, was still relatively uncommon with 2.2%. Importantly, and somewhat counterintuitively, rectal chlamydia in women is not associated with receptive anal intercourse. So a lot of the studies that looked at this first just screened women who'd had anal intercourse, who reported anal intercourse. It made sense. Those seemed to be the women who were at risk for them. But some studies uniformly screened women and found that actually the rates of rectal chlamydia among women who did not report anal sex were comparable to the rates among women who did report anal sex. So this is one thing to think about as we're thinking about screening, is now we're talking about screening all women who are getting chlamydia screening for rectal chlamydia as well, if that's what we're considering. So why is that? That is, again, counterintuitive. There's an interesting hypothesis that has been advanced about GI acquisition or oral acquisition of chlamydia that then sets up shop in the GI tract and in the absence of inflammation can cause persistent rectal infection. We don't have any data on this in humans. We don't really know if this is based on mice and mouse chlamydia, but it is an intriguing hypothesis. That said, we don't really know what the clinical and public health significance is of extragenital, I'm focusing now on rectal, chlamydia and gonorrhea in women. And it's important for us to really think about this when we think about screening, because we don't want to just find it because it's there and treat it because it's there. We really need to think about what is the morbidity that we are trying to prevent with this action or with this investment. really, the thing that would tell us about the public health significance of rectal chlamydia, I'm now focusing on in women, is if we could define its role in urogenital infection. So if women who have rectal chlamydia are more likely to have urogenital infection or to have treatment failure for urogenital infection and have all of the morbidity associated with that, which is some proportion going on to PID, ectopic pregnancy, and infertility, then we have a clear public health significance of rectal chlamydia, but we don't have that information yet. So Christine Kosrapor is really focusing on a lot of this work with one of her grants and did an interesting study I'm going to show you next, although I just want to run through the rationale for this first. So if rectal infection is contributing to urogenital chlamydia among women, and if azithromycin is inferior to doxycycline for the treatment of rectal chlamydia, as I just showed you earlier, then we would expect differential treatment failure with azithro versus doxy for the treatment of urogenital chlamydia in women. And in general, meta-analyses have shown no significant difference between azithro and doxy for urogenital chlamydia treatment. However, Christine did a really interesting and intriguing study of Washington state cases of chlamydia. So this, again, real world, women with chlamydia in Washington state, almost 269,000 of them. Most of them treated, as seen on the left, with azithromycin, 63% of that. 25% of them, though, a large number, treated with doxycycline. And the rates of persistent or recurrent CT, so importantly, this was essentially patients who had another positive result in the window after treatment of infection. The rates of persistent or recurrent CT were higher for women who were treated with azithromycin, nearly 7%, than those treated with doxycycline, 5%. And that was a significant difference, as you can see in the risk ratio of 1.4 and the adjusted risk ratio. So azithromycin was 63% of treatment, but accounted for 80% of failures. And Christine is doing some ongoing work to look more at this. I think we aren't at the stage yet. My personal opinion is that extragenital screening of women as a standard practice we're not at the stage yet where that should be universally recommended, but I think we may get there with more information. Okay, so that's what I just told you, my opinion, not yet. You can tell me your opinion soon, but right now I get to tell you mine. Okay, so controversy number 2, should we test for Mycoplasma genitalium? So Mycoplasma genitalium, some of you very familiar with, others maybe haven't even heard of this organism. MGen has a population prevalence in the US estimated by work that Lisa Manhart led with, let's get back to this. Population prevalence among those who are 18 to 27 in the US is estimated to be about 1% overall, with slightly more common, 1.1% in men than in women, 0.8%. This is less common than chlamydia at the population level, more common than gonorrhea with 0.4%, and trichomonas, which varies vastly geographically, but in the US as a whole, 2.3% prevalence. On the right, you can see prevalence of Mycoplasma genitalium in clinical populations, which is much higher, of course, than in the general population overall. And here you can see that the rates of MGen are around 16 to 17% compared to those shown for gonorrhea, chlamydia, and Trichomonas vaginalis. So Mycoplasma genitalium is definitely a prevalent and common infection, especially in sexual health settings. What does it cause? The most well-known association is nongonococcal urethritis. I would say we know that Mycoplasma genitalium causes nongonococcal urethritis. There remains controversy about the extent to which Mycoplasma genitalium causes the other syndromes shown here. Although you can see the risk estimates, there is definitely a pattern of association of Mycoplasma genitalium with several STD syndromes in women as well. Treatment is where we really get a little stuck right now with Mycoplasma genitalium. So if we know MGen is common and we accept for now, for the purposes of discussion, that it causes morbidity in both men and women, should we screen for it? Should we treat it? So I'm going to focus now on treating MGen, should we test for it? Should we test for MGen in men with nongonococcal urethritis, the setting in which we have the clearest link to a known cause and known morbidity? This table shows treatments for M. genitalium, which are already hard and getting harder. So doxycycline, despite the fact that there's good in vitro susceptibility, really has dismal cure rates, 30 to 40%. Azithromycin, 1 gram times 1, one of our alternate treatments for NGU, about 40%. I realize I'm glossing over a lot of data to give you sort of the big picture on effectiveness here. And rapidly emerging resistance. In many areas, 40 to 50% of MGen isolates are resistant to macrolides. Quinolones, moxifloxacin, which has been the best studied and is the most effective, were initially very effective, 100%, but over time and with more recent studies, that has decreased. We are seeing the emergence of quinolone resistance in some areas, and the efficacy of treatment has gone down to somewhere in the range of 69 to 88% in a few recent studies. Once we get past those three, we don't really have any good options. Pristinamycin, 4 times a day for 10 days is one potential option. We don't have good data on the efficacy of that, but for us as a mostly or entirely US audience, that's not available in the US. It isn't an option. And spectinomycin has been successful in 1 case report. That's the level of evidence we're talking about. So this is where I think we really run into challenges around both screening for MGen and testing for MGen in the clinical setting is exactly what we will do with it and how we will design effective treatment and respond to emerging antimicrobial resistance. So I do want to review nongonococcal urethritis treatment and show you what the alternative might look like in a setting where we had MGen testing. So really importantly, the treatment guidelines depend on microscopic assessment of urethral discharge to rule out gonorrhea. That is something that I realize doesn't happen in all settings. It doesn't even happen in all STD clinic settings, unfortunately. And in many settings, we do syndromic treatment of urethritis. But in a setting where you can do microscopy of urethral discharge and rule out gonorrhea and diagnose nongonococcal urethritis at the time of the visit, the CDC guidelines recommend azithromycin or doxycycline as first line, followed by, if that fails, trying azithromycin if they got doxycycline first, and treating for trich in areas where it's prevalent. That does not include King County. And then going to moxifloxacin. Our guidelines bump moxifloxacin up to the second step. So in the King County STD Clinic, although I would say doxycycline is preferred, and we've had lots of discussions about that, doxycycline and azithromycin are still both acceptable first-line treatments for NGU, followed by moxifloxacin for treatment failure. So this does not include MGen testing, but interestingly, the European and the Australian guidelines both do recommend MGen testing for all men with nongonococcal urethritis, and preferably macrolide resistance testing as well. And here's what an alternative with testing might look like. This is a summary of the Australian guidelines at present, which is doxycycline plus MGen testing with macrolide resistance testing at the time of initial presentation, followed by, based on those test results, I'm sorry, this is an error, I should take out the persistent or recurrent, based on those test results to then follow the doxycycline by moxifloxacin or azithromycin if it's macrolide susceptible. So this is an area of ongoing work. MGen tests are commercially available, but aren't recommended to be used routinely right now. Controversy number 3. I have shown you already a lot about single-dose azithromycin. And this is something we've relied on in the STD treatment world for a long time now. It is very appealing. Again, single dose right now, 100% adherence. I can watch you take it. But we see not only growing resistance among GC, perhaps to a threshold where it's, we need to consider removing it. We also know that it is probably less effective for rectal CT, and it definitely is less effective for symptomatic urogenital CT, although only slightly. And we're seeing high and increasing resistance in Mycoplasma genitalium. So this is a simplified argument, but a big part of what's behind many people in the field saying we need to just stop using single-dose azithromycin. We've been too tied to that. We need to change the treatment guidelines. And Hunter, I will invite your comment on this in the discussion session, since I know it's something you've thought a lot about. The counterpoint is really how much we need and use azithromycin. It is cheap, it is easy to obtain, and again, we know about adherence in patients. This one is a hard one. Okay, the last controversy, doxycycline for STI prevention. So doxycycline has been studied for both post-exposure prophylaxis and pre-exposure prophylaxis for STDs. The setting here in the rationale is that doxycycline is uniformly effective, or I should say there is uniform susceptibility for doxycycline among chlamydia, never any cases of resistance, and among syphilis, although it's our second-line drug. Gonorrhea, it varies by location. So this was studied, the biggest study to date was from France, where men who were on PrEP in a study called the Uptake study were randomized to take doxycycline PEP, that is a 200 milligram dose, one time after sex. It was supposed to be around 24 hours after, it could be up to 72 hours. And the other arm was randomized to just no PEP. It was not a blinded study. This was targeting in France chlamydia and syphilis because the resistance rates to tetracyclines among gonorrhea are so high. And their outcome was the time to first STI. And that did decrease in the doxycycline arm, as you can see in the Kaplan-Meier curve, with a hazard ratio of 0.5. Really a pretty impressive decrease, although still a small study. There was no evidence of risk compensation in the study. 7% of the men discontinued the pills, and it was a median of 7 pills per month. So not that much, really a week out of a month. Sorry, not that much compared to taking it every day. Basically a week's worth of doxycycline, or not a week, I'm sorry, since this was 2. There was a median of 7 pills per month. This has been also studied as pre-exposure prophylaxis in a much smaller study of 30 men who had sex with men in Los Angeles who'd had at least 2 episodes of syphilis after HIV. And the goal here really was to see if taking doxycycline every day for pre-exposure prophylaxis would reduce recurrent syphilis, as well as GC and CT. This study randomized men to either once daily doxycycline or contingency management, interestingly, where they would receive essentially increasing amounts of money for staying STD free. I believe it was $25, $50, $75, $100 at around the 3, 6, 9, 12 month mark. That contingency management didn't change sexual behavior. There was no difference in behavior between the 2 arms, but there was a difference in this small study in STD outcomes. So there were 6 STDs in the doxycycline group and 15 STDs in the contingency management group. So I view this as preliminary data, but there is a lot of enthusiasm for it. There are some doctors who are prescribing it. There's one city in the US where it is actually recommended citywide to use doxycycline pre-exposure prophylaxis for at-risk MSM. But in addition to the fact that this is very preliminary data and we don't yet know how effective this is, there are big potential downsides, as I suspect all of you recognize right away. Antimicrobial resistance is a big one, not just among STI pathogens where we've been thinking about it in this talk and where it's perhaps easiest to measure, but more broadly in the microbiome. What are we doing if we're giving somebody doxycycline a lot over time? And then adverse effects of doxycycline. While it's generally a very safe drug, there are some adverse effects, and we are balancing this against what we're preventing, which is STIs, most of which do not cause substantial morbidity. We can, for the most part, cure STIs without any long-term effect. Syphilis and neurosyphilis are certainly the exception to that. While we continue to debate this, and I think there is really equipoise, we don't have enough data, it is interesting to me that patient interest is already surging in doxycycline for post-exposure prophylaxis. So we surveyed, our colleagues in San Francisco and us in our STD clinic, PrEP patients, surveyed patients about their interest in this idea. So this is admittedly people who just heard about the idea from us, may or may not have known about it beforehand. There was a Grindr survey in 6 US cities, that I believe was Seattle, San Francisco, Chicago, Birmingham, and I'm forgetting the other 2. 89% of those who were HIV positive. So sorry, I should back up. Grindr, as I think most of you know, but for any of you who do not, is a geospatial networking app that allows men who have sex with men to find partners ready to have sex in the immediate area. 89% of HIV positive men said they were interested in taking doxycycline. 86% of HIV negative said they were interested in it. In the San Francisco Ward 86 clinic, the largest Ryan White Part C funded HIV clinic, 75% of patients said they were interested. 90% of patients in the city clinic, STD, said they were interested. And here, of our STD clinic patients PrEP patients who we asked, 90% were interested. So it's pretty remarkable to me. Those are really high numbers. So should we prescribe doxycycline post-exposure prophylaxis? I would say that my opinion is we don't have enough data. This is not something we should be doing uniformly. My own opinion is there are also rare cases where it makes sense, especially for patients who have a discrete period where they know they are going to have a lot of high-risk sex activity, such as traveling to another city for a pride parade with plans to have a lot of sex during that limited period of time. I think it may make sense, and I think some clinicians are prescribing it in scenarios like that. But without doubt, we need more study. I do think it's possible that patients may get ahead of this on this one. In San Francisco, they report that patients have been going online, getting doxycycline, and sharing it broadly. So we'll see what happens. Okay, I want to finish up in just the last couple of minutes talking about upcoming things in STDs here locally in Seattle. The Oz study results are going to come sometime in 2019, I believe. This is a randomized controlled trial of CSF-guided syphilis treatment, LP versus no LP, that Christina Mara is conducting. This will be very informative since we've had a long-standing controversy about the role of LP in managing syphilis. 31 patients were randomized, and interestingly, the most common reason for not randomizing was that the providers, we recommended LPs. So there were 149 patients who chose LP and weren't able to be randomized, and 41 who chose no LP. That will finish follow-up in 2019, and we look forward to seeing the results. There are some things in the pipeline for gonorrhea treatment, including 3 that I've shown on this slide, and due to time, I'm not going to go into detail. We have several studies starting soon that I just want to highlight. I realize this is most relevant for those of you here locally, but the RCT I mentioned earlier of azithromycin versus doxycycline for rectal chlamydia. There is a study of GENT treatment for pharyngeal in GC that Dr. Lindley Barbie is going to be leading, in a clearance study. So we're going to be very interested in finding patients with pharyngeal GC. And we also have a phase 4 RCT of single dose versus 3-dose treatment with bicillin for early syphilis that we're one of 9 centers conducting nationwide. And possible future studies in the works. There was a proposal put in, led by Connie Kellum here at the UW, and jointly with San Francisco, to study doxycycline post-exposure prophylaxis. We will find out about that soon. There are proposed studies for oral acquisition of chlamydia, immunology studies to inform syphilis vaccine development, improvement in syphilis diagnostics, and prednisone as adjunctive treatment for otosyphilis. So I realize I'm just putting those up here, but I think want to convey there are a lot of people doing interesting work and really on the forefront of STD research here in Seattle. Some resources for those of you who do not already know about these, especially those of you on the webcast. There is a consultation line that the Prevention Training Center runs that allows you, if you have a clinical question about STDs, to just enter it in the system and let us know how urgent it is. And somebody from here at the University of Washington will get back to you with advice. And the national STD curriculum that CDC sponsored and that David Spock and his group at UW here created to facilitate education on STD clinical care in particular. And this is a really well done curriculum that I would encourage any of you who are interested to look at or to encourage your trainees to use. Okay, so I would like to acknowledge the folks on this slide who helped me and gave me input and answered email questions with preparing this talk. Thank you very much. And thank you. All right, I'd love to hear questions or comments, especially on the controversies. Bob.
Thanks, Julie. That was really wonderful talk. I had a question on the screening for complicated syphilis. You listed gait instability. Is that a screen for vestibular problems, or is that a screen for long tract neural problems? And if it's the former and they have a normal audiogram, then where is the syphilis in otosyphilis? Is that a cranial neuritis, or is that the other side of the blood-brain barrier and the otic?
That is a very interesting question that I'm going to let Christina answer after repeating it for the webcast. So I think the way to repeat that succinctly is with gait instability, what are we really screening for? Is that vestibular syphilis? And then I think the question is about otosyphilis and really where on the side of the blood-brain barrier is that? I'm not sure I repeated that correctly, but I bet Christina heard it.
Thanks, Julie. We didn't intend for it to be an otosyphilis question. So I think we were more thinking it was going to be a TABES question. And it just turned out there were a small number of people, but it was highly associated with an abnormal, with a reactive CSF VDRL. Your other question is, where is otosyphilis? I think that's really interesting. And I don't know if Mina's here, but she is heading up writing a review on otosyphilis. So we've been looking at this. And otosyphilis can occur because the nerve is in the CSF space and is damaged, but it can also occur in the temporal bone or in the cochlear apparatus. And it's very hard to know where. And we're trying to figure out if there would be some kind of test, like a brainstem evoked potential or something that we could use to answer that question, but it's unanswered.
Thank you very much, Dr. Mara. Hunter, I'm going to let you just say it into the webcast.
Great talk, Julie. Since you mentioned that azithromycin, to expand a little bit on the biologist Roger Rank's observations, his treatment studies were in mice, but he makes the observation that every mammalian species he's looked at, which is many, have their own version of chlamydia, and that's almost universally a GI colonization, and that in general, macrolides seem to work less well than tetracyclines in eradicating it. And he asks, why would humans be the only exception? And that from that follows some of the issues you spoke about in terms of the effect on treatment. A possible take home is that with chlamydia, more than with gonorrhea, for example, and certainly more than syphilis, we have always seen the occasional patient, usually a woman who screens positive, who seems to genuinely be at little or no risk, not sexually active recently, with in a reliably monogamous relationship. And I think we probably need to be a little bit more circumspect for some of these women in particular about when and where they acquired their infection in terms of what we imply to them about their sexual partnerships. The only other thing there, you're otherwise outlining of the controversies and uncertainties about azithromycin for chlamydia, for gonorrhea, for M. genitalium, and in general use of azithromycin in single dose is going to be the subject of a symposium at the Dublin STD meeting coming up in a little over a week, and another symposium also at the National STD Prevention meeting in Washington, D.C. later in the summer. So this is an area of active discussion among people interested in STD prevention and treatment.
Great. Thank you very much, Hunter. Okay. Anne.
I have a question that relates to Hunter's comment about implications for people's sexual partners when you, so I have a number of gay men who have HIV who swear up and down that they are partnered, only have one partner, and that their partners are monogamous, and they don't want to pay for a syphilis test. And so I would like your view on what to tell them.
That is an interesting question. So I think just to outline, what I think is the thinking behind your question, right? That when we have patients who are in mutually monogamous relationships, we don't really know, nor do our patients really know whether it is truly a mutually monogamous relationship, right? And it's very possible their partner has other partners. I think that I'm interested in what others think, but I think that for somebody who's really in a mutually monogamous relationship, although I'm sorry, I'm having such trouble answering this because I think that the trouble is we know it's not always true and they may be at risk. And I think they definitely need screening at least once yearly because they fall into that not high risk group as long as they don't use meth poppers and those other things. I have with the screening with every blood draw, even with those patients just said, we are doing this as a clinic, and just letting them know that it's added on and sort of taking an opt-out approach, which is what I think in most cases is probably the best approach to that question. Brian.
Thanks for a fantastic talk. Two super quick questions about syphilis. One, for neurosyphilis, someone reports hearing loss, urgent audiology eval, and I was trying to think through how that helps you. If someone reports hearing loss, how does that help, I guess, with that question? And then you also mentioned what's upcoming is there's a study, I think if I read it right, of 1 versus 3 doses of bicillin.
But those are two excellent questions, Brian. Thank you very much. I'm going to answer the second one first, which is I showed that there's a study coming up of 1 versus 3 shots for early syphilis. Is that still controversial? Do we need a study? I would say that it is not controversial here in King County and in Washington, but it is controversial in other areas. So there are areas where clinicians still routinely treat early syphilis with 3 shots of bicillin, especially among HIV positive patients. And the NIH decided that it was worth investing in a study to definitively answer the question. The first question is about what audiology evaluation of patients with syphilis and hearing symptoms, how that affects our treatment plan. And I think that's a great question that I'm again going to let Christine answer, in part because we corresponded about this beforehand. So why an urgent audiology evaluation?
I think that if somebody complains about hearing loss and has normal audiology and isn't complaining about tinnitus, I would probably be okay not treating them for otosyphilis. But if they complain about tinnitus, there's no objective test for tinnitus. So I'm stuck there. And then of course, the other advantage of getting the audiometry is if it's abnormal, it gives you something to follow if their CSF is normal.
Great, thank you very much. And I know we're a few minutes over, so thank you everyone and have a good day.